All right. Thank you everyone for joining our second Ask the Experts. We have with us today three great experts who need hydrated. I'll go ahead and let them introduce themselves and then we'll get to the questions. Go ahead.
Good afternoon. I'm Satheesh Chonat. I'm a pediatric hematologist at Emory University and Children's Spero Cataland. I'm excited to be here.
Ara Metjian, I'm an adult hematologist. My focus is on thrombosis and hemostasis, specifically in TTP.
And my name is Spero Cataland. I'm an adult hematologist from Ohio State University in Columbus, Ohio. I'm very happy to be here with you all today.
Okay. One of the questions that was not answered from last session dealt with how often you routinely check Adams TS13 on a patient diagnosed with ITTP. So what is your current practice and what do you recommend?
All right. I think so obviously, to answer this, I'll just tell you what I do. In the hospital, we've diagnosed immune TTP, so Adams TS13 deficiency with an inhibitor. Before my patient leaves, I like to check another Adams TS13. And if that is still low, then I'll check it regularly while they're coming in for their CBCs until we see that the Adams TS13 level has gotten to greater than 20%. At that point, I'll then stop the caplacizumab, and then we'll start tapering it. But usually once the patient has achieved an Adams TS13 remission, in which their Adams TS13 level is greater than 20%, then about every 3 months, every 6 months, every 3 months I'll check, and once it's persistently within the normal range, then I'll start tapering that out to at the least once a year. I'll check the Adams TS13 levels.
Yeah. So there's really no set standard. One of the things we tried to do with some of our work is to try to standardize how this should be done. And I agree with Ara that the upfront treatment, especially as you're stopping caplacizumab, is very important. Our concern was to sort of help create a paper for one of our blood journals looking at how often recommendations. And what we came up with, sort of what I talked about earlier, is every 3 to 6 months checking the Adams TS13 activity when patients are in remission, trying to stay ahead of be able to predict the risk of relapse. But as Ara said, there are some patients who can't make it there as often and may come from further or may have more stable activity. You may space that out a little bit. So maybe the best answer is every 3 to 6 months, but individual circumstances vary how far you have to travel. Some with multiple relapses who may be more likely to need preemptive therapy. So no set answer yet.
It's another question from our last session. Are you guys able to read it?
Yeah. Yes. Does the relapse of TTP always have a gradual decline of Adams TS13, or can it happen extremely quickly, i.e. between 3 or 6 month blood checks? Good question. I can start with it. So it's a great question. Does relapse of TTP always happen gradual decline? It's important because that's the reason that we actually recommend doing this Adams TS13 levels every 3 to 6 months so that we can look for that gradual decline if that's the case. And there are certain patients who do have a slight decline in the Adams TS13. So the trend is important rather than just an actual number. Secondly, yes, it can happen extremely quickly. But that's why we actually tell families that if there's any symptoms to look for it and seek help and let them know that the patient does have TTP so that whoever's seeing them at the emergency medicine doctor or internist, that they can actually measure that in TS13 levels along with the other blood counts that look to diagnose the first time or to look for relapse. Is that what your practice as well?
Yeah, I mean, that's exactly right. There's no perfect strategy. The idea is you want to check it often enough to give you time to do something to prevent a relapse. And we know that times it takes a couple of weeks to start to work, but you also can't check it every week or every day. You can't do that either. You wear people out that way. So 3 to 6 months has sort of been the initial approach that generally got adopted and was sort of confirmed by some of the French studies who monitored patients and showed there was enough time to pick up relapses and treat them to prevent that. Patients, I shouldn't say pick up relapses, pick up Adams TS13 relapses and be able to intervene and prevent.
Okay, next question.
All right, and the next question has to deal with everybody's favorite topic, COVID vaccine and TTP. If you are a TTP, and let's make it general, TMA patient, when is it safe to get a COVID vaccine and or COVID booster?
Okay, I'll take that one. It is once we know that a patient is in remission, I think it is safe to get a COVID vaccine or the booster. In terms of safety, there is really no good data that supports that the vaccination with the Johnson & Johnson and the AstraZeneca ones can create rarely a TTP-like process, but the others do not. And so in order to protect our patients from COVID, which probably has a far greater chance of causing a relapse of TTP or of leading to like injury and death, we recommend that patients get it. That's because there's no safety issues with Moderna or Pfizer. Now, if someone has received rituximab, then it's a question whether or not the vaccination or the booster will even be effective. And if someone has just received the course of rituximab, then what we know from lymphoma patients, getting a vaccination or a booster it's just like getting a hole punched in your arm. It's not going to be of any benefit, but there really is no harm. And I think most of us are agreed that to prevent COVID-19, to prevent the death and injury from COVID-19, we recommend getting the vaccination.
Yeah, that's a great point. One thing that we also tend to follow is that, especially if they're fairly stable in remission, we do recommend at least getting a blood count if they're worried about a week or two after COVID vaccine to make sure the platelet count is not going down. But otherwise, it's right. We recommend COVID vaccine in all patients with TTP.
Yeah, I agree. There are some reports of recurrences of TTP in people who got the vaccine and were less than 20%. Sort of that serving as that second hit. Again, that's a rare event. We say if you have above 20% ADAMTS13 activity in the case of TTP patients, it certainly makes sense to get the vaccine. There are always rare things, autoimmune events that can happen with anybody with any vaccine, but the benefits of the vaccine far outweigh the risks. Getting COVID itself is in general far worse than getting the vaccine, so you need to keep those things in mind as well.
Do you have any research or data explaining why some folks relapse more frequently than others? And make it as general as, or you can talk about with ITTP versus a recurrence with TMA as well, or with complement mutation.
I'll take, since I talked about this earlier, I mean, they're all slightly different animals. In immune-mediated TTP, it seems to be at this point related to, in remission, the risk of relapse is related to the ADAMTS13 activity, younger age, and we think people who have had multiple relapses might be at risk for doing it again. So that's who we focus our discussions about preemptive rituximab or cyclosporin or splenectomies on. The other congenital TTP and the complement TMAs are more related to the underlying biology of each individual's disease itself. It's hard to generalize. So patients, as you've heard earlier, with complement variants are at greater risk for relapse. People who develop it younger in life are likely at greater risk for relapse. But that's where a lot of work is going to understand that. What do you guys have to say?
Yeah, I think that's true. Actually, talking about TMAs other than TTP, especially complement-mediated TMA, at least in childhood, there's several times there is a higher risk of childhood infections, colds and coughs in the first few years of life. So there is a slightly increased risk that we've seen, especially with atypical HUS, like flares that are coming back in. But most of them can be fairly managed very well as long as they come to the hospital early on and the parents understand what to watch for, and as long as they've had a reasonable remission. So it's important to also tell the primary care physician or pediatrician or whoever they're seeing that the patient does have atypical HUS or TMA, so they know that to get some blood work or urine and so on, so that we can actually detect these early.
With just one point with immune TTP, I think the first part, we know, I mean, the simple response is, for those patients who have persistent ADAMTS13 deficiency, we know that is probably the most significant risk factor. Now, the more important questions: what is the reason that someone develops an autoantibody? What's the reason of all the enzymes in the body that the immune system attacks this one specific enzyme? We don't know that. And what's the reason that for some people that one course of steroids and rituximab can prevent them from getting a relapse for years or decades or ever? We don't know that. We know the USTMA published our research on, we know that our patients of African descent tend to be at a higher risk for relapse. They tend to not, the ADAMTS13 inhibitor tends to come back sooner than for those of Caucasian descent. But what's the reason for that? We don't know. And that's why it's an area of active research.
I'm going to ask Satheesh a question. So we talk about people with a complicated TMA, a genetic disorder they're born with and presenting earlier in life. So when we look at anybody who presents earlier in life as maybe a greater risk for relapse, does that apply in your world in pediatrics? Is there anybody with or without a variant that you might stop therapy in a patient with a complicated TMA?
So assuming a patient has complementary TMA, the most common being the atypical HUS, where they have a known genetic defect, certainly, I think there's a group of patients with certain complement variants are at a slightly higher risk of relapse. And the more challenge, what you've noticed is some of them have chronic kidney disease. So I think all they need is a very small trigger, a small virus to trigger that, whereas a similar patient with a slightly different complement mutation, the same infection, they may actually do okay. I think there's a lot to learn. I think there's a lot of biological variables that we tend to see in addition to the underlying complement mutation. So hence, close follow-ups, looking for maintaining, optimizing the kidney health is very important, and also diet and growth and so on in these children, just so that we ensure that they're adequately immunized or vaccinated. So we're trying to prevent as much as possible.
Thank you.
How is it possible to have ADAMTS13 above 100? Is there any significance to that?
You can.
I guess it all goes back to what's the question? What is normal?
There are very specific cases where an increase in ADAMTS13 activity takes you to the other direction of TTP. So an absence of ADAMTS13 activity, less than 10%, leads to this thrombotic microangiopathy, the creation of these ultra-large pathogenic multiples of von Willebrand factor. In very rare cases, which probably you're not referencing, so which means I'm not even answering your question, in liver transplant, in patients with what's called LVADs, or these mechanical hearts, you can have an increase in ADAMTS13 activity that can lead to an increase in bleeding. But I think it's probably safe to assume you're not asking about liver transplant or BIVAD patient or aortic stenosis. But usually in the setting of someone who's had TTP, if it's above 100%, I mean, that could just be the way the lab has calibrated. If normal activity is 100%, I mean, if you're 101, 105, 110, it's still greater than 100%. That could just be where they say the lab has said normal is 100%. And that could just be average. It may not even be one of these conditions where there's a increase in von Willebrand factor proteolysis or cleavage. So in the setting of TTP, I don't think I would just nod my head politely and move on.
It's just hard to know what to do with it. Some of the data I showed earlier, the Rotterdam data, where they looked at healthy people aged 55 or older and measured the ADAMTS13 activity, and the group with the lowest quartile, the lowest 25% of that group, and majority of them were still normal by their lab standard, had a greater risk for strokes and TIAs over that follow-up time period. So, like Ara said, there's two different things. There's lab range of normal, and there's studies that may help us to understand what level is required to prevent certain things. It's very complicated, obviously.
Yeah, no, I agree. I think it's from a laboratory testing standpoint, there are 2-3 major ways to test ADAMTS13. So I think it's important to recognize there could be a small error in how the blood is collected, and there could be other things in the blood could be interfere with the testing. And sometimes it could be a small errors in especially the high levels of anti-estrogen activity. So it's so hard to know, was it really 90 or 100? So there's a few of the caveats, but that's important because as long as it's being managed and reviewed by someone who's comfortable in taking care of patients with TTP, that makes a difference.
I wouldn't worry about it.
All right. Having a little loading issue.
Well, we have a very nice patient who, in remission, did not recover her ADAM-TS13 activity, and this is published as a case report. And even after rituximab, did not recover, and after COVID-19 vaccination, developed an acute TTP relapse within 5 to 6 days of the vaccine dose. So it's always hard when we make these associations and say it was related to the vaccine that triggered it. It's really just a timing thing. That seems to be in the window where it was related, so we think it was related. But if it would have been 14 days later, maybe 21 days later, it's hard to know. So do we have a case that that's happened? Certainly. I think that served as the second hit in somebody who had undetectable activity. A unique situation.
I mean, just to be more precise, I'm unaware of any cases of someone who's gotten COVID and then a normal ADAM-TS13 level then dropped to less than.
Right. I'm talking about, I should clarify now. I'm talking about a patient with a history of TTP.
Right. That's what I mean.
Right. Yeah.
With a history of TTP where they have normal. So just, we talk about an ADAM-TS13 relapse where it was normal and now it's less than 20 versus a clinical relapse, which is both of those, platelets less than 150 with an absence of ADAM-TS13. So my concern is in the patient who still has less than 10% or is hovering around the 10 to 20% range. And then if they get COVID, that will set them off. I mean, I think we've all anecdotally have had patients who have had, the minor sore throat, cold, whatever, like booger virus that kids have brought home from school, and it has triggered the immune system and set off another relapse. And if it's something, I think this is what harkens back to what we're talking about. If we can avoid a serious infection with COVID with immunization or vaccination, it's why I would recommend getting that. But I think it's, can it happen? Probably, but I'm not aware of anyone who had a normal ADAM-TS13 level then plummeting.
But of course, we just don't know because someone who's never had TTP before, we never know what their ADAM-TS13 activity. There are people running around without adequate ADAM-TS13, less than 10, 20%. We just don't know about it. And they may get COVID and that may lead to a problem. So there's a lot of unknowns in here.
Yeah, but I think for a person with known immune TTP, I'm not aware of that now.
There's also a pretty normal variation in the ADAM-TS13 activity that we don't necessarily understand completely either. So
I'll let you answer this one.
What's the last question?
Have you seen?
What percentage of people have a single TTP episode versus those that relapse more than once?
So the largest database that I'm aware of is actually our own report, and it was overall is 34%, slightly higher, 40% in blacks, 26% in white. So I think a third of patients are destined to relapse at some point. The longer the follow-up, and this was about 25 years of follow-up. So I think that's a pretty good number. But if you've relapsed, it sounds simple to say, but if you relapse once, so episode number 2, you're more likely to get 3, 4, and 5. If you just got it the first time, I think the number is about a third of the time. But it's hard to know when that window ends. The longer you follow, that number might grow just a bit.
Yeah, that's a good point. So we just looked at our pediatric data for the last 20 years. It's important to remember that there's been changes in the treatment, how we treat these patients. We try to do upfront rituximab. So we have seen that our relapse rate was higher if we actually divide them into first 10 years and second 10 years. The relapse rate has gone from about half of them to closer to like 30%, similar to adult ranges. So which kind of speaks to how we've been managing patients with immune TTP the last few years.
Is it right to say that COVID is a trigger of AHUS, or does it come as its own TMA like E. coli does for HUS?
Yeah, no, it's a great question. So, yes, so for those who don't know, there is E. coli. The most common is called the sugar toxin, which causes the hemolytic uremic syndrome, which is the HUS. The AHUS, or atypical hemolytic uremic syndrome, is typically because of an underlying complement mutation. Again, it's only about 70% of them or so that we actually detect a complement mutation, so not all of them. So back to your question, is it right to say COVID is a trigger of atypical HUS? I have not come across, for the very first time, patients coming with COVID with atypical HUS. Certainly COVID can have symptoms of TMA, and that's been well shown. People have actually run clinical trials to see if complement inhibitors can actually help treat patients with COVID. But I've certainly had patients, and there's reports of patients with known atypical HUS with COVID infection having a trigger. So certainly, like we discussed earlier, in COVID as an infection or inflammation can certainly trigger. If you already have the complement mutation, you actually need a trigger. It used to be some other infection, but now there's certainly, we talk a lot about COVID, and it also gets reported. Previously, there are a lot of these colds, viruses that we don't necessarily go and publish all those cases. So there's also slight bias with COVID, but we know COVID is a very serious infection. Hence, we probably see more cases reported. Is that our experience in junior adults as well?
Yeah. Also talk, because sorry, not to belabor it, but if you think about thrombotic microangiopathies, there's TTP, there's atypical HUS, there's HUS, and there's also something called DIC, which is what we call this consumptive coagulopathy. We know that COVID, whereas E. coli is more of a toxin mediated, and atypical HUS is complement dysregulation. COVID can also cause a DIC-like syndrome where you have this consumptive coagulopathy. So it can look like TTP or any of the other sort of thrombotic microangiopathies. So, again, it can do any of this in the susceptible host, which is why we're very keen on preventing it from happening to begin with vaccination or immunization. Just a subtlety I want to make.
It's on that little diagram I showed with TMA and all the different causes. A very sick patient with sepsis, infection, inflammation can look just like that. So it's hard to know when you see a patient that sick with COVID. And as Ara said, there were studies, there was findings of TMA in some of the sickest patients and studies to study the role of these complement blockade therapies. I'm not aware of any of the results that have been published. It's probably too late that somebody that sick maybe to see an impact, but it's hard to say. It's hard to know what is a reaction to the drug, what may be triggering something underlying. It's very difficult.
Is there any genetic connection in families with blood disorders? My daughter has TTP and my cousin has von Willebrand's.
Assuming, I'll take it from a pediatric standpoint. I'm assuming this is, it could be congenital TTP or immune TTP. Certainly immune TTP, I don't believe there's a connection. Congenital TTP, again, I do not believe there's actually a connection. It's important to recognize that, if it's families who are autosomal recessive, the families are related, so they could be, but I'm finding it hard to actually get my head around between those two different proteins.
Because I'm trying to think because how I could explain that if there was a connection aside from being in the family, because von Willebrand's disease represents the other end of the spectrum of what leads to TTP. In von Willebrand's disease, you have either a quantitative deficiency or a qualitative defect of von Willebrand factor. So the type 1, type 3 von Willebrand's disease, you're just not making enough of it. The type 2s, what you're making is just not functional. Whereas TTP, it's the exact opposite end of that spectrum. You are making, not that you've made too much, but what you've made is this pathological, super sticky von Willebrand factor that binds to platelets when it shouldn't. It's literally the exact opposite expression of von Willebrand's disease. And the only thing that could, if the diagnoses are correct, I can't think of any way to connect it. And if I had to really cram the square peg into the round hole. Maybe if there was something called type 2B von Willebrand's, where that can actually present with thrombocytopenia, but that presents with bleeding, not with end organ damage, schistocytes, kidney dysfunction, like any of the other things. So I can't see how to directly link those two together. I think it's just true and unrelated. Yes, your daughter has TTP. Yes, her cousin has von Willebrand's, and that's it. That's the only connection.
Yeah, I mean, there are clusters of families that seem to get more autoimmune diseases.
Yes. Right.
But not necessarily TTP, anything like
Yes.
that. And again, as you say, von Willebrand disease are rare acquired forms, but it's a congenital disorder.
Right.
The things that you're born with.
And I know you didn't ask this, but unless it's congenital TTP, we don't really see this there yet. Like, yes, there is in families a higher risk of developing of autoimmune disease, but if your daughter has had immune TTP, there is not. I mean, I would never say, oh your grandchildren or her daughters or her children would then get TTP as a result of it. In that setting, it is not genetic. I know it's not what you asked, but I wanted to throw that out there.
We gave you a bonus.
Yeah. All right.
I saw my cousin. I think my cousin Vinny, which is a movie I enjoyed. But my cousin Von Willie instead.
Is it safe to take vitamins and supplements that could help maintain a healthy immune system as a patient with TMA? I'll throw that last part in there for you.
I don't think they heard it. Yes, and it is safe to say, and I'll even expand upon that. Yes, you can take vitamins and supplements once your TTP has been treated. If you want to take it, you can. I mean, generally speaking, a normal healthy diet is probably all that you need. Probably a vitamin is probably all that you need. I don't recommend to my patients, if someone says, look, I'm taking 5,000 milligrams of vitamin C, you're going to end up peeing out about 4,500 of those milligrams. You can take it. It won't harm you at all. Take it one step further. Once someone has had a diagnosis of TTP and they're in remission, that is part of their history. And that should never be used as a reason not to get standard of care. So if someone says, you need a mammogram, you need a colonoscopy, you need a prostate biopsy, you need to go on this medication for your depression or your thyroid or blood pressure, you should get it. Just because someone had TTP, there's no reason you should not get standard of care.
Exactly. Don't forget the obvious because of the TTP.
Yeah.
Don't ignore the
I
obvious.
agree. The only thing I tell some of my patients is to just bring the supplements or vitamins. So they tell us what you're taking, just making sure it's not like herbal medications. Some of them can be harmful. So at least you can discuss with someone before taking it.
Yeah. Moderation, a good healthy diet, rest, good clean living.
Yes.
Will there be a cure for AHUS eventually? Is there technology to do it?
Yeah, that's a great question. I can certainly answer part of it. It's a complement-mediated TMA, so we see a complement dysregulation. It's important to note that there's several complement genes that could be affected. So it's not like one gene causing the disease. So several genes, and like I mentioned earlier, there's a few patients with atypical HUS, we don't even know what kind of underlying complement dysregulation that they have. And like we discussed earlier, we're learning more and more about it, why some patients actually with the same gene might not ever have a flare-up, never come in with renal failure or drop their platelets or have hemolytic anemia, but another patient with exactly same complement genetic mutation could actually present early on in life. There's also some more to learn in terms of triggers in those atypical HUS. So I think it's important to understand those before we kind of go into a cure. To my knowledge, I don't know if there's anyone who's tried a gene therapy for atypical HUS. There's certainly a lot of work is done in selected diseases such as hemophilia, sickle cell, thalassemia, very blood disorders. So certainly, there's going to be advances in the field to help understand this further. Is there technology to do it? Yes, the technology is rapidly advancing, so it's really an exciting time. But I'm not aware of it has actually been done ever.
I think you're right. You need to know the exact genetic defect and that it's going to altering that will alter the risk for the disease. And I don't think we know that. Maybe in some patients, we don't know it enough. I mean, there used to be, it sounds funny to say, there used to be a cure for the disease prior to complement blockade therapy. It was kidney liver transplantation combined used to be done. And you're replacing a liver that's going to make a different protein, we presume a functional protein, but that's a pretty drastic step and not something that's being done right now due to the effectiveness of complement therapy. So that's technically a cure. You almost accomplish the same thing. And that's really the question. Do you need a cure? Can you accomplish the same thing with the right treatment? And that's the $10,000 question.
Should babies be tested at birth for ADAMTS13 levels for preventative and preemptive reasons?
Yeah, that's a great question. Assuming that you're talking to help prevent congenital TTP, because as we know, immune TTP is usually not presented this early in life, especially at birth. Our youngest was about age 3, but again, it's usually immune-mediated TTP. So in congenital TTP, should they be tested at birth? My personal opinion, I don't think they should be, because that does involve a lot of testing, and we still don't know. We believe they should have near normal levels, but we still do not know a lot more about what could be the case. Now, can we identify a select group of babies who may present with severe jaundice, drop their platelet count, require plasma infusions? Because some of these actually looks like severe infections or sepsis. So it could get overlooked as sepsis, and the plasma infusion sometimes is given for sepsis, or they call as DICs, which is where there's a coagulopathy. So in those babies, I think it's important to carefully look to see, this is the baby that we need to follow, and should we consider getting ADAMTS13? I think we're a little further away because we still don't screen this in a routine babies at all, and we have been doing it in a very selected babies. But it's an excellent question.
Yeah, I think the radar is up higher than it was 10 years ago, 20 years ago. But there are a lot of things and I'm not a pediatrician, but there are a lot of things that happen at birth that could be considered consistent with TTP, but also a lot of other things. So it's one of the things that has to be considered. And that's, I think, what Satheesh is saying, that's where the focal testing is. Not everybody.
It's about 1 or 2 per million cases is a congenital TTP. So it's still very, very rare compared to immune TTP. So
maybe I flip. I'm sorry, I'll flip your question to the older population who are at risk for other cardiovascular disease and strokes. And as information is starting to accumulate, that it may be a risk factor, along with family history, smoking, hypertension. There may be a scenario where people get checked in the future for other reasons. Some of the data I showed were lower, but even normal levels may have a greater risk for strokes. It may be one of multiple risk factors we use together. But you have to know why you're doing it before you order it. And the next question is, how do you increase it reproducibly, which is another interesting question.
Is it more cost effective as well as clinically effective for the management of an AHUS patient's treatment to undertake genetic testing? So do you get genetic testing on your patients?
I do. For anyone with TMA who we think that we want, when we consider TMA in a child or pediatric patient, the patient presents with TMA, once we rule out other secondary causes, including infections such as E. coli and sugar toxin, then we consider is it atypical HUS. It's important to know this. There's not great blood tests which are actually available to confidently diagnose 100% of the time. So we're actually trying to put a lot of things together. And you're right, absolutely. We also send genetic testing. As mentioned earlier, it's not positive in 100% of the patients with atypical HUS. So while it's cost effective, I think the cost for genetic testing was remarkably reduced in the recent years, and we're able to actually go into deeper sequencing and picking up those variants which we are able to identify to cause this disease. And I'm trying to understand what's clinically effective. Now, it certainly can help direct the treatment to some extent, or especially more for follow-up and long-term follow-up, because there's some studies thinking, are there some patients who need to be on it forever, or could we potentially consider stopping complement inhibitor therapy in some patients with atypical HUS? So certainly, I think from that perspective, It has a benefit. So I strongly recommend doing genetic testing, not for everyone with TMA, but selected group.
And I would say also this might be a little bit more on the theoretical or academic level. These are always moving targets. I mean, before we used to say TTP and HUS were like the same thing, and now we know they're vastly different. And the same thing with atypical HUS. And while it's very well defined in patients who have two mutations in complement genes or the same mutation in both in the two copies are affected, we know that this is a moving target. And I would at least make the assertion that even if we haven't identified a mutation, at least if something comes up a day, a week, a month, a year, 5 years later, we already know what's been done. And we don't have to sort of recreate the wheel. And that if, yes, the atypical HUS panel was negative this time around, when we find what defines that other 30 to 50% of people who have no mutations, at least we've taken a step forward, at least in terms of determining what else is this. And this is always another area of research is what created atypical HUS in those patients who had no genetic mutations. What is it that we have not found? So I would make that plug also, that even if we don't find something, it at least helps us out later on in life or later on in the course of this as we do more research.
I agree. We fairly uniformly test all our patients we suspect of a complement-mediated TMA. But I think an important point there to mention is the genetics don't predict your response to treatment. Mm-hmm. So you don't wait on the treatment. You still may treat them with a complement inhibitor, but it may confirm the diagnosis. And as Satheesh already said, it may help predict who can more safely stop the medication in the future, which you could view as being more cost effective if someone could stop that expensive medication.
Yeah. I want to also clarify that if we think it is atypical HUS, even if the complement mutation is negative, we still go ahead and treat the patient.
Do you think the reason ITTP happens will ever be determined or discovered?
Yes. I'm done. No, I think there's research that was done through the University of Pennsylvania where they saw in a select group of patients who had a marked, there was a very strong association with having contracted influenza. Now, I think if I had what I would guess is that in the future, what we're going to find is that there's going to be a risk, a score, a panel that says, okay, in this susceptible person who reacted with this virus, let's say, and we use virus a lot because that's something similar called ITP in children. We see that happens a lot. It may not be the same for everyone, but probably we come up with a good model for in this susceptible host with this environmental trigger that 1 + 1 = 3 and led to the development of an autoantibody against this of all the enzymes of ADAMTS13. While we may not be able to prove that to the nth degree, I do think that we will eventually find more and more parameters as to what caused this, how this happened.
Yeah, I agree. I think we're never going to know exactly who's going to get it, but we're going to be able, as Ara said, identify who's more likely to get it. We know now it's females more than males, blacks apparently more than other races, but that's obviously a large group. I think we will get to the point we can narrow it down with some other biomarkers, either whether it's genetic testing or other types of immunologic testing to narrow down, hey, this group may be more at risk for it. Maybe it should be higher in the list than this group. And maybe lower on the list in this group, but at this point, it can still happen to anybody.
In this sort of scenario, we see this all throughout medicine. It's not just TTP. A condition that we'll see, something called hemochromatosis, very common in people of like Western, Northern European descent. Having these mutations doesn't mean you're automatically going to get the disease. Something called acute porphyria. 80 to 90% of people who have mutations in the enzyme never get the disease. What are those other triggers? What are those other things that drive that second, third, fourth hit that leads to the expression of the disease? Yeah, we don't know yet, but we are finding out what else is leading to it. I think those days of where there's like one thing leading to one process, we sort of have figured out the easy, simple stuff, and all this other stuff that has more shades of gray. We're still in the process of learning, and then even then, we all change, right? How I was 10 years ago is not how I am right now. No, hitting 45, definitely I went over a cliff, that's for sure.
Well, there's risks for different things in different ages. You're exactly right. We change it. Well,
Are there any correlations or causations between TTP and other clotting disorders?
No. I can't think of it. I mean,
I think you have to consider clotting disorders, what type of clotting you're
Yes.
dealing with. Venous thrombosis versus arterial versus large vessel arterial disease such as strokes and heart disease, and small vessel arterial disease such as TTP and some of the long-term complications of diabetes and sickle cell disease. So I think TTP, it may look like other things, but it's fairly unique in its cause.
I mean, was there anything in particular? I'm trying to think if there's nothing else. Okay. No, I can't think of, it's its own beast, which is very different. It's very different from someone who has a blood clot in their veins, a DVT. Very different from someone who, develops a heart attack. It's its own entity. And I can't make that connection between TTP and those other conditions.
Is the time coming to retire the term AS? And do you guys want to talk about the new term that we've been utilizing a little bit more today?
And it's a good question. I think there's certainly different groups of thought. Atypical HUS have been very traditionally used. There's literatures of decades of literature of atypical HUS. The idea behind using complement-mediated TMA is to ensure that we divide the patients. One, it's important to kind of put the patients together because there's a lot of similarities. It can actually help in diagnosing these patients early so that we all look at them together and we work them up in a similar fashion. So one of the advantages is to be able to actually work them up early on and help in teaching so that people don't have to learn multiple different terminologies and so on. Because some of the treatments are very similar as well in the complement-mediated TMA, at least in the initial few days or weeks while we're waiting for the results to come back. But I think it's important to recognize that there are atypical HUS which are caused by certain mutations which are more from a clotting cascade, such as the DKEC mutations, so which are not necessarily complement, necessarily dysregulation. So my take on it is I think we're hoping that once we know all the mutations which cause atypical HUS, then maybe yes. But it may also help to put them on a complement-mediated TMA, just so that we can actually certainly correlate the ones which all may, and it helps us to learn better too, and we can actually offer more support. What are your thoughts on that?
Yeah, I mean, there's efforts actually underway. So myself and some other members of our consortium are involved with an effort from the National to make the terminology match the pathogens, and that's where I'm getting retrained over the last year or two to start using the term complement-mediated TMA because it more reflects the disease, the pathophysiology, and the target. Whereas atypical HUS still means a lot of things to a lot of different people and can be misleading in terms of the treatment. Old things die hard, though.
Yes.
All right, I just want to thank everybody who joined today. Thank you to our experts for doing such a great job. Make sure you come back at 3:10 for patient initiatives. And in this short interim, make sure you swing by the sponsors page. You do have the option to talk to any of the representatives there with the button that says click here, join us, Zoom, enter chat room, whatever they labeled it. Go ahead and say hi, tell them what's important to you and why they should support research in your area. Thank them for supporting this meeting today. Thank you to our 3 experts on the panel here, and thank you to everybody for your questions.